Lakshman, thanks a lot for giving us all the insights regarding what are all the causes of constipation and the lifestyle changes that can affect and the dietary reasons that can affect the constipation. We will go into the next topic of if a patient comes to you with symptoms suggestive of constipation, what are all the investigation? How do you, what do you do? How do you proceed from here? Can we talk about on the investigations and stuff related to constipation, please?
Yeah, let me tell you about the symptoms which are suggestive of constipation first. So,
okay.
As one is patients may be passing bowel or opening the bowels every day.
Okay.
Even in constipation. So,
right.
If the patient says that I'm going daily, so it does not always make sense because what the effects of constipation is some amount of stool expelled or every day.
Yeah.
There's some stools retained in the body that we call it as constipation. So some people they open the bowels every day, but they'll be passing the stools which were formed 3 days before.
Right.
Progressively. So the next 2 days it will be there, and then the third day it comes out. So it's having the same effect as constipation.
Right. Okay.
So what symptoms we look for is after opening the bowels, do they feel that bowels, the rectum feels empty fully? That's one symptom.
Okay.
Secondly, whether they have to force to pass the bowels, expel the stools.
Okay.
Is stools very hard. So normally in the Bristol scale we grade it from 1 to 7. 1 is hard and 7 is like watery. So normally it should be 3 and 4 or 5. So if it's 1 and 2, it's dried or like a goat
pellets. Okay.
So these are indicative of that stools are retained in the body for a long time. So they get dehydrated.
Okay.
So that should be, you should start treating them as well.
Right. Okay. So
then how do we investigate that question?
Yes, yeah.
So when they have these symptoms of constipation, the first thing what we do is take an abdominal X-ray.
Okay.
That will tell us whether there is an retained or residue in the colon. It may be in the left colon, right colon, or pelvic colon.
Okay.
It also usually shows some gaseous distension because the stools in the bowels, if they stay for a long time, they will be acted upon by the bacteria to produce more gas. That will cause bloating and distension.
So in layman's terminology, the patient will be coming out with swelling or discomfort in the abdomen, and he will be passing flatus. All those kind of symptoms will be there. You get an X-ray. In the X-ray, there will be some gas shadows in the X-ray. Yeah.
Yeah.
Okay.
That will tell us about the location and confirmation of constipation. Then we look at the blood test, whether there is any metabolic cause like diabetes, thyroid, or any other cause. Clinical examination will give us clue about any diseases which can cause constipation.
Okay.
And the other thing is about doing a transit studies, colonic transit studies, it's called. Some people call it as shape study. Anyway, where this will assess movement. In some diseases, the whole colon is slow, sluggish bowel.
So there won't be much movement of this large intestine. Okay.
Yes, it will be slow from the first part to last part of the colon. Slowly moves over 2-3 days. So it stays in the other is.
So you do colonic studies. Yeah. What does it exactly involve, the colonic study? Is it like you give some barium or something, or what does it involve?
We give some 20 markers, radiopaque markers.
Right. Okay. So from this point of time to that point of time where it moves. Yeah.
Right. Okay. So after 3 days, we take an X-ray. We can see all the 20 markers in the bowels. That means it's not moved.
Moved at all. Okay.
Sometimes it will be scattered all the way from one end of colon to other colon. Sometimes all the markers are in the rectum and staying there for 3 days.
Right. Okay.
So colonic transit is fine, but at the end they stay back in the rectum, asigmat. That is exit constipation.
Right. Okay.
If it still stays in the whole of colon, we call it as slow colon or sluggish colon.
Okay. So these investigations gives you an idea at which part of the large intestine the problem is accordingly. Yeah. Right. Okay. So you did the X-ray, you did the blood test, now you did the colonic studies. Is there any role of any scan or anything at all here?
Usually, we don't need to do any scans, but we do one called MR or MRI scan of the rectum, MR proctogram. That will tell us about the position of the rectum.
Okay.
Whether there is any pelvic floor dysfunction.
Oh, you mean the muscles that support the whole of the bottom?
Yeah.
If they are not properly contracting in order to let go of the feces, then you call it as pelvic floor dysfunction. Yeah.
Yeah. The pelvic floor or the muscles in the pelvic floor are supposed to support the rectum to allow bowels to open easily, but it doesn't. There will be weakness of the pelvic floor muscles and the rectum dips deep, so that there will be angulation. That can be assessed.
Right. Okay, that can be assessed. So these are the investigations. And with this one, you will be able to get a clue as to what exactly happening. And accordingly, you will be treating the cause of the constipation. Yeah.
Correct. So to learn the effects of constipation, we do colonoscopy because one of the complications are fissure in ano.
Oh, right. Fissure in ano. Okay.
Yeah, because of the hard stools, there can be tear in the lining of rectum.
Yeah. Okay. Of the rectum. Okay.
Yeah.
So because of the pain, the patient doesn't want to open the bowel, or because the fear of pain. Is that right?
That causes spasm. So it causes constipation as well as it will make it worsen.
Okay.
And once you open it, it causes severe pain. So they tend to avoid it further.
Right. Okay. Okay. So it goes into a vicious cycle essentially. Pain leading on to patient not wanting to open the bowels, leading on to hardening of the stools, once again opening, and it becomes rigid. Yeah. Okay. All right.
And because of the pressure, there will be piles or hemorrhoids which can form.
Okay.
And the third thing is because of the internal pressure trying to push the stools out. So there will be pressure build up that can cause diverticulosis.
Right. Okay. So
and the fourth one.
Okay. Right.
And again, because of the coating of the stools, the bowels will be coated with stools because it don't function. It causes a paradoxical overflow diarrhea. So basically, it's constipation.
Okay.
So since the bowels are coated with stools, they cannot do their job, like absorbing the water.
Okay.
So it will go along the sides and stools will come out as diarrhea. So,
right. Okay. So the constipation will be manifesting as a diarrhea. Okay. Right. I understand what you mean here. So the unevacuated feces goes and lines the walls of the intestine where normally the water gets absorbed. But in this condition, as the feces gets lined on the walls, water doesn't get absorbed. So there is a lot of water in the colonic cavity itself, which is going to come out as diarrhea. Okay.
Yeah, similar. Yeah. We'll not go into complications. In a simple way, yeah, that's all. Colon doesn't do its work, resulting in diarrhea. But the basic problem is constipation. For the diarrhea, if you give more and more anti-diarrhea drugs, it makes it worse.
Right. Okay. Okay. Dr. Lakshman, thanks a lot for giving us insights about the investigations on how to go ahead with the constipation and the biomechanics that are involved in constipation. Let's move to the next topic, Dr. Lakshman. So you were mentioning about the complications that can be associated with constipation. What are the complications that can happen here?
Yeah, we discussed about the fissure in ano.
Yeah, fissure is essentially tear in the wall of the rectum or below down. Okay.
Yeah. Then hemorrhoids which are soft cushions of blood vessels, which can start bleeding and which can come out of the anus at severe degrees.
So it's called piles, yeah?
That's correct.
Right. Okay. So first is fissure in ano, which is essentially a tear. Second is blood vessels getting bulging out. Okay.
Third is the diverticulosis.
Right. So
diverticulosis by themselves may not be very manifesting, but they can get infected, inflamed. So that causes pain, bleeding.
So diverticulosis is essentially the pressure within the cavity of the large intestine increases, as a result of which there are pouches that are forming into the muscular layer of the large intestine, like some pouches, like balloons there. So that is called diverticulosis. And if the feces goes and gets impacted, then it gets infected. Yeah.
It may get infected. Sometimes they stay without any problem, but sometimes these pockets can get inflamed because of the irritations. Sometimes they get infected too. So diverticulosis can result in diverticulitis, where when there's itis, they get pain. Blood in the stools, diarrhea, all this can.
Right. Okay. Can the diverticulitis, the pouch, can it burst and cause some infection of the tummy itself?
That is very rare.
Okay.
You don't get that. But inflammation is good enough to cause symptoms.
Discomfort, pain, etc. Yeah.
Yeah. One of the common problems in the Western countries and Western population is that diverticulosis
and the treatment for that is going to be, is it going to be surgical intervention?
Not necessarily always. We can start simply with the treatment of constipation. Secondly, in an acute diverticulitis, antibiotics, anti-inflammatory drugs, and laxatives.
Right.
Maybe admission for some time. Very rarely, this diverticular can cause stricturing, narrowing, so which may require surgery.
Right. So there's a scar tissue formation happens, which narrows the lumen of the intestine, which can cause problems for which surgical intervention might be necessary. Okay. All right. Okay. Any other complications? What if the constipation happens and the toxins are getting absorbed by the body, and does it cause any increased ammonia and affects the brain functionalities and stuff like that?
No, it produces so many toxic gases, not just ammonia. There could be some methanes and could be sulfur containing sulfur oxides, etc. So anyway, there are so many toxins which are getting absorbed into the body. They can have different impact on the nervous system, bodily system. You feel much tired, irritable, all those things. Non-specific symptoms which get better with treatment.
Right. Okay. Now, before finishing off this particular conversation, because we are going to keep the treatment of constipation in the next episode, before going on to finishing this one, can you please tell us that does age has got a bearing on the likelihood of experiencing constipation at all?
Yeah, as you know, naturally, when the babies are born, they will be passing 5-6 times, say 8 times motions. Whereas in the elderly, it becomes less. So elderly, not just physiologically, it becomes less. In addition, their activity will be less, their eating may be less. So all this contributes to more constipation in elderly.
Right. Okay. Okay. So if that is going to be the case, I'm sure there will be a role of exercises or physical activities in contributing to bowel irregularity. Is that the scenario, Lakshman?
Yeah, currently the diet and inactivity or sedentary lifestyle is contributing a lot to the constipation. So we can discuss in detail about that when we talk about the treatment.
Treatment of it. Fantastic. Dr. Lakshman, fantastic insights. I learned a lot from today's conversation. I'm sure our viewers will also be brimming with knowledge after they have gone through this particular episode. I cannot honestly thank you enough for passing your insights to the general public regarding this particular stuff. Appreciated, Lakshman.
Thank you so much. And that is the intention of our talks.
Absolutely. Right. Let's meet you once again in the treatment of this constipation in the next episode. Thanks, Lakshman. Bye-bye.
Yeah. Bye.